stents to clean clogged arteries help in prevention of heart attacks. Is it true or false?
False.
Okay. Bringing blood pressure to ideal 120 is one of the best ways to prevent future cardiac-related diseases.
True.
Aggressive management was metabolic biomarker, which is HbA1c, to optimize level of 5 or 5.5 is the best way to prevent chronic diseases.
False.
GLP-1 drugs are miracle drugs, and everyone should take it just for a longevity standpoint as well.
Absolutely false.
Statin is a miracle drug. There is a saying from America itself that it should be dissolved into water, and people should start drinking from tap water once they are 40. Is it true or false?
I'll go with false for that as well.
Okay. Daily consumption of calcium and vitamin D is one of the best ways to prevent fractures.
False.
Multivitamin should be taken by all because all are somewhat deficient in one of these.
False.
Common knee and back surgeries are generally placebo-like surgeries. They don't do any good for the patient.
I'm going to go with false. I think that's more on brand if I say false for that.
Okay. You come from USA, I come from India, and in my part of the country, doctors are either placed as a pedestal of God, or they are told that it is a noble profession. And nowadays, it is the polar extreme, which is they are pharma-funded drug peddlers. They have some malintention to loot yourself, or something that they want to do more surgery so that they can put a chip on their shoulder, or they want to put you on the medication so that they get more recognition among their peers and among the pharma industries in their CMEs. So this is the polar opposite, and I know it is a spectrum. The best part is the middle path, and I think you belong to the middle path, which is the sensible medicine. So from foundationally, I want you to let us know about evidence-based healthcare, because first of all, what is the current scenario of majority of doctors, and what is your recommendation that we should be following?
So when I think about evidence-based healthcare, evidence-based medicine, I think of it as combining both knowledge of sort of pathophysiology, how the body works, clinical experience, and evidence from the best available trials. And to recommend a practice, you really should have a foundation of those three things. We get into problems in medicine when we lack one of those, let's say, legs of the three-legged stool. If you're going just on pathophysiologic reasoning, a lot of things that seem like they should work don't actually work. Clinical experience is good, but you can absolutely be fooled because of the placebo effect and because of the usual sort of course of disease. And trials are very good, but they often don't apply to the patient in front of you or give an answer for a population. And we don't take care of populations, right? We as doctors take care of individual people.
Yeah, right. So what is this term called medical reversal? Can you explain as someone who is an undergraduate or is in a high school? How is it the idea or the theme is different from the current medical practice that is really common globally?
Sure. Ideally, every practice that we adopt would have a robust evidence base, right? It would make sense pathophysiologically. We'd have some positive clinical experience, and then we'd have, robust randomized controlled trials that say it works. That's unfortunately not the case. A lot of things are adopted based on a really good story, and then maybe a manufacturer of a device sort of pushing it and, producing a couple of observational studies or maybe a small flawed randomized control study. We adopt that therapy. And then sometimes, often years later, some brave soul says, I'm a little bit suspicious about this. Let's test it. And they design a randomized control trial that shows, look at this thing that we've been doing for 10 years and have spent, millions, if not billions of dollars on, actually is no better than what we had been doing or better than placebo, and we should stop doing it. And when that happens, we call it medical reversal.
So, sir, that means that the current practices, the majority of current practices are somewhat to be skeptical about. If correct me if I'm wrong.
Yeah, I usually say, I'm a physician. I believe in medicine. I think that most of what I do is right. But I am also a skeptic. And so what I like to say is that if I, refer a patient to someone for back pain and the doctor says, "Ooh, I've got this new procedure that I can do." My question is immediately, what's the evidence that that works?
Yeah.
And
Hmm.
I don't want to hear from that doctor, "Oh, well, the last 3 people who I did it to, they did really well." I want something, more robust. I want to see a
Okay.
published trial that's well done that I can read and say, okay, I sort of buy this. And that's not available for many of the things that we do.
So can you talk about your 40% finding that you mentioned that you had reviewed something and 40% of the medical practices that have been currently practicing by the global physicians have been somewhat useless or somewhat harmful when it comes to patient long-term care or long-term prognosis. Can you expand on that? Your study was that? What were the markers that you looked and all that?
Yeah, so this is work that I did with my colleague, Dr. Vinay Prasad. We said, how can we actually put a number on this? How common is reversal? And if you think about it, it is really an impossible question to answer
Yeah.
because you'd have to say, okay, I'm going to look at everything doctors do. I'm going to assess the evidence behind everything that doctors do. When there's no evidence, I'm going to design that trial and I'm going to do it. And that's like, a career journey with infinite amounts of money.
Yeah.
So what
Right.
we did is we started with looking at one journal, the New England Journal. We
Okay.
looked at 10 years of publications
Okay.
of every article that was published in the New England Journal where an already adopted practice was assessed with a randomized controlled trial. And we showed that about 40% of those trials showed that what we were doing worked. About 40% showed that what we were doing didn't work, and about
Okay.
20% were kind of a wash, couldn't really tell from the analysis. So that 40%, it's not a perfect number, right? That's
Yeah.
gone through sort of the editorial decisions of one journal. But as we did more and more research over time, what we found is that these medical reversals are not rare. They're not something which are just striking, so we talk a lot about them, but they're common and we see them
Okay.
quite frequently. And I don't know if the real number is 15% or 40%, but there's a lot of it.
And it is considerable chunk also because it is nearly half. As you mentioned, 40 is clearly close to 50 rather than close to 0. So it is something to be talked about.
Yes.
Can you name some case studies about that? Because majorly there are a lot of drugs which are really common for preventive diseases or secondary prevention or lifestyle related disorders, chronic diseases, non-communicable diseases. So in that light, can you tell us about what are the interventions that you had flagged that this doesn't work and they are epitome example of medical reversal?
Sure. Let me maybe start with the easiest one and kind of the clearest one, which is a
Yeah.
surgical example. So, a decade ago, one of the most common surgeries on the knee in the United States was arthroscopic surgery for degenerative meniscal tears. So this is an older person, all of a sudden their knee starts hurting. They go to the doctor does an MRI and says, "Oh my God, look, you have a meniscal tear, a tear of your cartilage in the knee." And for years, doctors' response was, "Well, we see something broken. We're going to go in there and fix it," right? Makes total sense. Pathophysiologic rationale. And some of those people after the surgery, lo and behold, after 6 weeks of rehab, they were better. Clinical experience, right? Supports it. And then a brave researcher from Finland did actually a randomized control trial where people were randomized to this arthroscopic knee surgery or actually sham surgery where they brought people to the operating room, made little tiny incisions so it looked like they'd have surgery. And you know what? The two groups did exactly the same. And that group has recently published 10-year follow-up. And in fact, the group that had surgery looks like it does a little bit worse over 10 years. So that's
Right.
like a classic reversal in the surgical sphere.
So one of the line that I had written after reading your chapter 1, the practical takeaway was, do not assume a treatment works just because everyone is doing it, because it is a herd mentality in the medical peers. Demand evidence that is that extends or improves a life. That is the summary of medical reversal. Now, coming to a term that you have used really nicely, which is subjective outcome. There is something that can't be measured enough, because it is highly subjective. A patient that tells I'm fine and a patient that tells I'm in pain, they are completely different, and we can't grade them, that which is better, which is bad. So can you expand over that how we measure a subjective outcome, rather than, as you mentioned, that there is a surgery which was really highly practiced, and it was as good as placebo. So
Right.
how to measure a subjective outcome in that case? Because surgery is like the patient is already in pain or is in dysfunction. So how do you measure that?
Right. That's a great question. And subjective outcomes are interesting because it is much of what we all take care of as doctors, right? It's people who aren't feeling well and want to feel better, right? That's a subjective outcome. It's not the objective life and death, stroke or no stroke, LDL of 50 versus LDL of 120, right? The hard part about subjective outcomes is that when you're looking at an individual patient, it's almost impossible to tell if the drug that you've prescribed or the procedure that you've described has made the difference. Because all of us know, right? Every day you wake up and you feel a little bit different. Some days you feel better, some days you feel worse. As you get older, I've got decades on you, right? Like when I feel perfect, I'm like, I gotta remark on this because that's a remarkable day. And so what we demand when we're talking about therapies for subjective symptoms is we want large randomized control trials where the treatment, whatever it is compared to a blinded placebo. So that may be a matching pill, it might be a sham surgery, whatever. And then what you have is you'll usually find that in the placebo group, 20, 30, 40% of people get better. Why did they get better? They get better because we told them we'd get better, that we were doing something to help them, or just because the disease gets better. In the treatment group, maybe you have the same, 40% get better. And if that's the case, then the money you're spending on the treatment is a waste of time. You should just care for patients and they'll feel better over time. If the benefit in the treatment group is 60%, then you say, wow, my care for this person will help 40% of people. The actual treatment will help another 20%. That's probably a treatment worth adopting.
Dr. Adam, I would like to tell my personal example, because I practice primary care in my day-to-day life. Not anymore, but I was practicing after my med school. So whenever a patient comes, let's say is pre-diabetic or is on a verge of getting into type 2 diabetes, I generally tell it that take care of your diet, take care of your exercising, take care of stress levels and all that. And that person goes, the patient goes home with the feeling that the doctor doesn't know a thing, because he hasn't prescribed a drug to me. The thing is, people have this notion that whenever I go to doctor, they will give me a pill, they will recommend me a medication, they will do a procedure on me, which is like a magical wand, and I would go home cured. They don't want to take an agency of taking their condition head on. So there are the examples that you have mentioned in medical reversal. I would just quote it for the viewers as well. One is arthroscopic knee surgery, one is ACL tears, one is asthma, one is irritable bowel syndrome, one is angina stents. Now, sir, if such patient comes to an office and you just tell him or her that this is nothing, intervention is needed, you just need to take care, there is no major surgery needed for such condition, that patient might go home on sad. Do you get what I'm telling? They will be telling that this doctor doesn't know. This doctor is out of his mind because I have this much pain, I have this much dysfunction. Then also he's telling that we shouldn't go for surgery. So in this case, how we stand upright to our principles of evidence-based medicine, to our principles of medical reversal, and how we do the right thing? That's my question.
Yeah, I wish I had an easy answer for that. We could probably talk about that for hours.
Okay.
I think in a way, medicine is a victim of its own success, right? Because there are a lot of things that we can prescribe a pill for and make it better, right? If you come to me with a urinary tract infection, with pneumonia, with diabetes, with high blood sugars, right? I can give you a pill or a shot and I can fix that, right?
Exactly.
And so we've sort of extrapolated that to, oh, there's always something to do. The other thing, I have a piece actually coming out on this in a couple of weeks, is that as doctors, we are trained to not take away hope from people, right?
Yeah.
We never say, "Oh, I'm sorry, I can't help you with this," right?
Yeah.
Um, which I think is the right thing to do, but in a way, it's made a lot of us hesitant to say, listen, there is nothing medicine can do for you here, but I can advise you, what you can do in your life to feel as good as possible. And I'm not talking about hooey crystal, meditation kind of stuff. I'm just talking about, living a healthy life as far as we know it,
Exactly.
as far as diet,
Yeah.
exercise, having friends, sleep, things like that. Now that's hard because we want to keep our patients satisfied. Some of our salaries depend on keeping our patients satisfied,
Yeah.
and it's often quite an effort to convince people that when you're recommending nothing, it's the right thing, and that
Yeah.
person's just going to not go to Dr. I don't know, JP Quack down the street and just get what the patient wants. So I think it demands a little time. It demands actually as a physician really knowing what the right answer is and putting in the time with the patient to discuss, listen, this is why this is the right thing to do. And this is why other people might recommend different things, which I disagree with.
Sir, you might have faced patients who are more of a AI illiterate. Means they will do all the research. They will come with the differential diagnosis. They will come with the alternative medications, and they will tell you that, sir, why haven't you initiated this? You are missing the point. They will
Yeah.
counter you. They will be a lawyer for their condition, and you would be feeling like my entire med school, my decades of experience is gone waste. So
Right.
there are a lot of my colleagues also who are now oncologists, who are endocrinologists. The patient they are interacting with, they are already coming with 5-6 doctors, different school of thought kind of diagnosis, and also the first line of treatment, and they do a confirmation bias, like what kind of drug they want, and they pick it, and then what you say, quarrel with the doctor that why haven't you initiated with this drug and that not. So I think that also is one of the huge kind of things that we'll be facing as a physicians going forward with the advent of AI tools and AI, what you say, research. So now coming to one of the key features which I personally loved from your book, that was about surrogate markers. We are living in the world of preventive healthcare, wherein the biomarkers, fitness variables are really coming common. Like a lot of middle class people also and billionaires also, they are hyper optimizing their life by tracking every small detail of their physiological or what you say, metabolic markers of their body. So when it comes to surrogate markers, correcting surrogate markers versus correcting the actual case, what's the difference between that from your lens?
I love the way you talk about that. When we wrote and I love it because I think the problem of surrogate markers has actually changed and gotten worse since we wrote the book.
Okay.
Um, when we wrote the book, most of what we were thinking were surrogate markers are things that we doctors care about because we think they predict worse outcomes. And we think that if we change those surrogate outcomes early, maybe we can help the outcomes later. We use surrogate outcomes mostly because they're useful in research, right? If I have a new drug which is supposed to prevent fractures in osteoporosis, I've got to enroll, thousands of people in my study. I got to wait 10 years until enough people have fractures that I can tell a difference between my drug group and my placebo group. If instead I'm not waiting for fractures, but I'm just looking at an improvement in bone density, right?
Yep.
Then I can get away with a study with fewer people and and a shorter length of follow-up, okay?
Yep.
There are some surrogate endpoints which are terrific, which have been proven to work, and I know, for instance, that if I lower a patient's average sugar, their hemoglobin A1C, glycosylated hemoglobin, from 9 to 7, that person will do better down the line. The person may not feel better at all, right? Because I'm just managing a surrogate outcome that they don't feel, but I know that they'll have, less retinopathy, less nephropathy,
Yep.
maybe even less heart disease and death later on. What's happened since we wrote the book, while we were obsessed with things like bone density and hemoglobin A1C and blood pressure measurements and cholesterol measurements, now we're like, patients are bringing us their surrogate markers.
Yeah.
Because everybody's, wearing a
Yeah.
smart watch or an Oura ring or whatever the hell it is, and they're bringing me pulse data, sleep data, temperature data, stress data. I don't know what to do with that stuff, right? Often I don't know if it's predicting something. I don't know if I give a medication to change that, whether it's going to pay off in the long term. And some people look at this stuff as, oh, this is sort of interesting. I learned something about me. Fine. But other people, it becomes like an obsession.
Yeah.
And it's all they want to talk about at their visit. And we in medicine, we are just far, far behind where the technology is in knowing that doing something does anything.
Yeah, right. Sir, this is an illusion of knowledge, if I may say so, because people are really, watching reels, watching short videos of content creators who don't have the relevant qualifications, and they come under the term called, which we commonly call bro science. Like they are optimizing the biomarker, they are optimizing the lab findings, they are optimizing a magic number that the companies have come up with their algorithms. Now, keeping that aside, I want to double down on 3 points. One of the first point is HbA1c. Given
Doctor,
that people...
Can I interrupt you for a second just because I want to highlight something you just said?
Yeah, sure.
So many people are getting information from content creators, and it's kind of funny because, look, you and I, right? We create content, right? It's part of what we do too. But you always have to think about, why are people creating that content? Because that underlies, what they're trying to tell you, right? And many, 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 many people are creating content truly just to maximize the clicks, maximize their income, whatever, right? And so you got to always take it with a grain of salt. And the same reason that we distrust some randomized controlled studies because they're designed and written by pharmaceutical companies, you also have to bring the same level of doubt and skepticism to that person who's yelling at you from the internet.
Yeah,
Sorry.
Exactly.
Go on.
Yeah,
I just thought that was such a good point. I wanted to highlight
it was a good point, and it is really relevant in current times. So I want to double down on 3 points. One of the first point I want to double down is diabetes and the metabolic syndrome. The core, biomarker that overlays the entire spectrum is HbA1c. Now, people with the use of CGMs, with the use of the smart trackers, they are hyper optimizing their metabolic markers. Like fasting insulin is one of that. HOMA-IR is also one of them, because it is really public. They don't need a physician's prescription to do a lab test. It is really possible because of a lot of health tech startups and companies that have come up with free direct to consumer kind of offerings. So what's your take on your trials? That there were 2 studies that you have mentioned. One is ACCORD and one is advanced trials, that you had mentioned that hyper optimizing the HbA1c didn't directly correlated to decrease in mortality or decrease in the complications. Can you expand on that? That what was the study and what was your finding that you had?
Yeah. So, to give a little bit of background, right, where we think about hyperglycemia, right, elevated sugar levels, has mostly been in this setting of diabetes. Okay.
Yeah.
And what we know is that the closer to euglycemia, to normal sugars you can keep people with diabetes, the better we do.
Yep.
And huge studies from back in the actually late 90s, early 2000s, the DCCT for type 1 diabetics and the UKPDS for type 2 diabetics, showed us that getting people down from an A1C of 9, which most people would be like, 9, oh my God, my head would explode if I was at that level. But that's the level at which most people are actually symptomatic from their high sugars. down to an A1C around 7 really pays great dividends in those people.
Yeah.
And so the question in the studies that you cited is, what if we go even further down than that? What if we go from a hemoglobin A1C of 7 to a hemoglobin A1C of like 6.5, recognizing that normal hemoglobin A1Cs are probably actually down in the low 5 range. And what the studies of that showed is that, probably doesn't show a whole lot of benefit and may even cause some harm because people have more episodes of low blood sugar, of hypoglycemia. Now, people have gone even further with that because they say, well, what if I'm not a diabetic? What if I'm a normal person who runs borderline elevated blood sugars, or maybe my blood sugars are just in the high normal range? So I have no idea what to make of that. Yes, people with metabolic syndrome over the course of their life are a little bit more likely to do poorly, right? Those are mostly people who are sedentary, who are too heavy, maybe overweight, maybe obese. I don't know whether medications make any difference in those people compared to just trying to live a healthier lifestyle. And so most of those people who are tracking those sort of numbers, I kind of say, this is maybe a lifestyle choice. And if it's helping you to say, maybe you shouldn't have that bowl of ice cream every night, I'm all for that. If you're here to give me a medication to change that number, I'm not sure that's the right thing to do right now.
So I'll be rubbing off a lot of endocrinologists off lately because one of the common finding, because you might have known that India is diabetic capital of the world, and we are currently facing a metabolic crisis. Lot of normal people are in the pre-diabetic or metabolic syndrome range, and if they go to endocrinologists along with the lifestyle interventions, the majority, as you mentioned, that 40% or 50% of, or even more, endocrinologists prescribe a drug. May it be metformin, may it be GLP-1, or may it be SGLP2 inhibitors. So what's your take on that? Is it a case of medical reversal that you are talking about, or there is a nuance to that as well?
I think we don't know yet. What I would love to say to those endocrinologists is, man, we need data. And please, 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 instead of prescribing these drugs, build an RCT and randomize those people, right? Because I would love to know that if you come to me a little bit overweight with a hemoglobin A1C of 7.2, normal in my hospital goes up to 5.8 is abnormal, 5.7 is normal. I generally try to keep my patients with diabetes below 7. So if you're 6.2, randomize those people. Randomize the metformin versus placebo. Randomize them to a GLP-1 versus placebo. Follow those people. And I don't care what their hemoglobin A1Cs are after you randomize them. What I care about is, in 10 years, are the people who've been on a drug for 10 years, are they healthier? Are they having fewer heart attacks? Are they having fewer strokes? Are they having less kidney disease? I want to know that, because I'd gladly write prescriptions if people want them and it helps them. The GLP-1s are tough, right? Because not only do they help surrogate outcomes, A1C, but they often help people lose weight.
Yep.
And for an adult who's obese and wants help losing weight, especially someone who's, been trying to lose weight for 20 years and have always failed, I'm happy to write them a GLP-1 prescription because it's probably the only thing which is going to truly help them to lose weight over time.
Sir, GLP-1 has taken it has gone like bonkers of lately, especially in your country, which is US, because everyone left, right and center have been prescribed or self-prescribing with the off-label usage, and they are rapidly going into transformations. They are transforming their body. They are transforming the body shaming kind of culture of lately, which has been on a decline due to the new age looks maxing stuff, or optimizing for a physical appearance. prescriptions. Now, coming to your I wanted 2 pointers that from your answer, the two threads that I want to double down on. The first of which was 10-year window that you have mentioned. I want to understand that what is this 10-year lag window that you mentioned in your book as well? That any drug need to be waited for 10 years before it can be, considered as a consensus guidelines for use for the mass public. And secondly, what's your take on the same for GLP drugs? Because GLP drugs are new age drugs when it comes to metabolic weight loss, and we are just 2 to 3 years, if not more than 5 years, into this new world of GLP prescription. So can you just expand on that 10-year lag and also in the light of GLP?
Yes, that's a great question. And so I think let me rephrase it. So, doctors can prescribe drugs essentially, the minute they hit the market, right?
Yeah.
And doctors are usually therefore acting on data that includes, 10, 20, 40,000 patients, right? However many people have been in those randomized controlled trials. And then, a federal agency here, it's the FDA, has sort of signed off on it and said, this drug is quote unquote safe and effective. Its benefit outweighs its harm. Our FDA doesn't consider cost, which they probably should. But in many countries, that's also considered, which is important. But the question is, there are things that are going to come up about those drugs over time. So what about those side effects that occur, 1 in every 100,000 people, right? That's not going to be detectable in the randomized controlled trials that are done to get those things to market. Nor are adverse effects that may be common but take time to occur.
Yep.
And so I think when you use a drug early, either as a doctor or as a patient, you just need to keep that in mind that this seems safe. Are you willing to take this? Probably being an early adopter takes a little bit of risk, right? I think it's probably, and maybe I suggested it, but it's probably unreasonable to say you need to wait for 10 years to institute any medical advance, because in our kind of society and culture that moves fast, if you do that, like, you're going to have no patience. But I do think it is worth saying, with these drugs in their sort of early years of their lifetime, we don't completely know what we're doing with those.
Again, I would like to rephrase, sir, your Dr. Adams and my also stands on this. These drugs are not evil. They only need to be prescribed. It is just like a tool. It is just like a knife. You can either kill someone or you can use it for a surgery to save a life. It is like you have to weigh the risk and benefit ratio when it comes to patient. So neither Dr. Adam is against these drugs. We are just against irrational use and the rampant use of lately with the public, prescriptions. So again, sir, the next biggest thing after the diabetic spectrum or the metabolic spectrum is one of the drugs which is statin, or let's say anti-lipid drugs. Now, this is really controversial topic, but I want to cover this comprehensively because statin generally has two kind of crowds. One, which is pro crowd. They are telling that this is a miracle drug. It will prevent heart diseases. It will prevent cholesterol and related diseases like Alzheimer's and the entire spectrum. And the other group is that it is really evil. You will have muscle pains. You will have side effects. It will do more harm than it will do good. Sir, what's your take on this when it comes to statin broadly? And then we'll go with the other anti-lipid medications.
Sure. I think you alluded to it before that, extremism or fundamentalism is always bad, right?
Yeah, it is the middle path.
Right. And so, statins are actually, when I think of maybe the 10 most important medications which have come into practice, which have become available since I became a doctor in the early 90s, statins are no question on that list because they are absolutely life-saving in people with vascular disease, okay? People with coronary artery disease, people with angina, people who have had heart attacks, strokes, whatever. And that means that they are effective. The number needed to treat, the number of prescriptions I need to write for one person to benefit is low, in like the 20 to 50 range, which is kind of gospel. On the other hand, what's happened, and you can argue it's because of true believers in medicine or because pharma's saying, there aren't enough people with vascular disease, to make this worth our while. We need to extend the people using this to everybody. In people at low risk, people who say have high cholesterol but have never had an event, or maybe people who have just kind of high normal cholesterol, or maybe people with normal cholesterol, what does it do to them? Well, these are safe drugs. So for most of those people, it probably does no harm. In a few of them, it will help, but no country could afford to, supply statin medications to everybody. And we'd probably, if we actually examine that data over time, would find harms that we haven't yet experienced once we're putting millions and millions and millions of healthy people on those medications.
So can you talk about the use of statins as a primary prevention and secondary prevention, because there is a medical reversal point there also. So I want you to expand on that.
Right. So secondary prevention is you have had an event, right? You have had a cardiovascular event, and we are trying to prevent you from having a second event. Okay. And that's where we have the most robust evidence in statins. And so when I tell a patient of mine, who's had a heart attack, that they need to be on a statin, and they say, "Oh, I've heard statins are bad. I'm not going to use this medication." Those are people who I rail against. And I sort of say, listen, it's your body. You can make any decision you want to make. But I think if you decide not to take a statin, you are making a mistake. I think that's a bad decision. Primary prevention are people who are healthy, who have never had an event, okay? And we have data for primary prevention, not nearly as good as secondary prevention. Most of our data is at high-risk primary prevention people. And that means, high cholesterol, risk for other reasons. I don't know, maybe they're a smoker, maybe they have high blood pressure. Okay. Yeah. And our data shows that yes, using medications for primary prevention in high-risk people is affected. The number needed to treat, the number of people we need to give medications for to prevent an outcome is certainly much larger than in secondary prevention. But it works in primary prevention too. The problem is primary prevention, there's a spectrum of primary prevention, right? Yep. There's primary prevention for high risk, moderate, and low risk. And in the United States, with the most recent ACC, AHA, the kind of cholesterol guidelines, what's happened is there's been a shift to using primary prevention in much lower risk people where the benefit is certainly less common.
Sir, just for a caveat, we will be covering the evidence-based spectrum of how to read a research paper and the term that you mentioned, which is NNT, and also ARR and NRR afterwards. But for now, I want to shift the focus on the new age anti-lipid medications, which is like fenofibrate, niacin, Ezetimibe. The focus has been shifted from statins to this new age medications just because of the adverse effect of muscle and the as the trend of statin falls, the new age trend of new medications rises. So what's your take on that? Because it has been used, this new age medications have been used to, optimize the term that you mentioned, surrogate outcomes, which is LDL, HDL, and also triglycerides to HDL ratio and all that. What's your take on that? Is there a medical reversal in that also?
Yes. And I would say, you talk about those drugs being new, it falls into the everything old is new again.
Yeah.
Right. So when I first trained, what we talked about, were, the fibrates. Okay. So gemfibrozol, fenofibrate, and niacin. Gemfibrozol, mainly a drug for treating triglycerides. Niacin, primarily a drug for treating LDL. And those medications really did not work on their own to treat high cholesterol. They worked on the surrogate outcome. They made your numbers look better, but they did not change clinical outcomes. Okay. Statins were such a breakthrough because not only did they change the numbers, but they actually benefited people. They changed their medical outcomes. And so those medications as sort of a backup to statins, you kind of have to say, is this doing anything, or is this just making my numbers look better and making people feel better? And it's probably the latter rather than the former. Ezetimibe, Zetia, which is, not a new medication, but came out post statins, is a medication which works differently, kind of decreases absorption of cholesterol, so decreases the sort of hepatoenteric circulation of cholesterol. It does lower numbers. The evidence we have for benefit is there, but the benefit is quite small. It does make the numbers look better. Mostly where ezetimibe has been studied is in people who are on statins, max dose statins, and hasn't reached their numbers, or people who can't tolerate max dose statins. And so again, using ezetimibe alone because people are like, I don't want to use a statin, also sort of questionable.
So, sir, before we jump into the next topic, just to clear the loop for this topic, which is diabetic and cardiometabolic association of cholesterol, high cholesterol, conditions. What's your take on what's the borderline wherein the lifestyle medication and the lifestyle intervention and the medication, there is a delineated line, which is, for example, let's say 250 LDL is one of the borderline after which we need to consider a medications. I'm just telling, I'm not telling it is right. I'm just asking you. And let's say it is HbA1c, wherein it is like 7.5 is the line, wherein we have to consider a consideration of a medicine rather than lifestyle intervention. Can you just lay down the generally consensus that we can come up with when it comes to the medical reversal that you mentioned?
You got it. So I think hemoglobin A1C is very easy for me because I think for most of my patients, I sort of tell them, when they're 6 to 6.5 on their hemoglobin A1C, I tell them, listen, don't get obsessed about this, but let's kind of look at low-hanging fruit, things that are pushing up your sugars that you can get rid of easy. That's the dessert. That's the sweetened drinks. That's the alcohol. Get rid of those things. They may be fine for somebody else. They're not fine for you. Once people are in the diabetic range, and let's call that 6.5 to 7.5, those are people who I say, we've got to really bear down on. Let's talk about your diet in detail. Actually, often I use nutritionists or my advanced practice nurses to spend a lot of time with that patient to really look closely at their diet. I counsel hard on exercise. I want you doing 30 minutes of aerobic exercise where you're a little bit out of breath every day to make those numbers look better. If after all that, those people are still running a hemoglobin A1C of 7, I'm going to use medications to get that down. Unless they're old or they're on tons of medications and then try to limit that.
Comorbid conditions.
Right. Push up their goal to 8. The lipids are harder for me. And what I like to do with that is I like to use one of the risk stratification scores. These days I use the PREVENT score most commonly. And what that does is allows, me to put in all this patient's data, not just cholesterol, but age and blood pressure and so on and so forth, to get a 10-year cardiovascular risk. What's your chance of having an event over the next 10 years? And then I can also put in, if I lower your cholesterol, what has changed about that risk? So maybe your risk was 10%, and with a medication, I can get you down to 6%, because that enables me to have a very kind of collaborative discussion with a patient where they understand what I can offer them. And my experience is that many patients are like, oh my God, 10%, that scares me to death. And then I say, well, that 90%, 90% chance you're going to do fine. And they're like, okay. That's not as scary. And then I say, and if you take a drug every day, I'll bring that risk down just from 10 to 6. And they'll say, Well, that's not much of a benefit for taking a pill every day.
Right.
But there are other people who are certainly like, wow, 4% benefit. I'm all over
Yeah.
that. Give me the
The
drug. I wish I'd
micro
started it yesterday.
optimizers. The
Yes.
micro optimizers. Yeah. Right.
Yeah.
So now let's come to the wellness industry. It is one of the booming industry of lately. And we were talking about medications, but the other part of the world of the entire wellness industry is supplements, or what you say micro dosing of what you say micronutrients and other supplements. So I want to cover that from your angle, from a medical reversal angle, because a lot of this comes from self prescription, like vitamin D, calcium, then other supplements like multivitamins, and we can go entire spectrum. Like it can go from commonly deficient vitamins and minerals, and also it can go on for add-on supplements which can boost your performance from a sports science or a gym science perspective. So what's your take on it? Let's just start with vitamin D and calcium, because it has been really rampantly used because of prevention of osteoporosis and the fracture related to the aging. What's your take on that?
So this is timely. There was recently, I think, a new Cochrane meta-analysis that looked at vitamin D that was remarkably negative as far as
Yeah.
improving bone density in
Yeah.
older people. So I'm not, a bone specialist endocrinologist. But I think where we are is that the most important thing is that people get, their calcium and vitamin D probably naturally by drinking milk, being out in the sun, exercising when they're young, between 0 and 30 when we do most of our bone building. So we're in good shape when we get to the later years. There are people who have diseases where they don't absorb vitamin D. Or medications which impair their ability to build bones or absorb vitamin D. Those people need to be treated. But for most people, what we need to do is we probably need to just screen them when they get older and say, wow, because of your genetics and your family history, whatever, you have very low bone density and we need to treat you. And we don't need everybody else in society thinking about, oh my God, I've got to be supplementing vitamin D from, age 30 onwards, because that probably does them no good.
Sir, of lately in the wellness industry itself, there is a trend of longevity or healthy aging or anti-aging, if I may say so, because of the branding. And the people are associating vitamin D and lot of medications like metformin, rapamycin, and other geroprotective or senolytic drugs for prevention or extension of health span and prevention of aging, what you say, senolytic effects on our cells and our organs. What's your take on this of lately, the trend of this, what you say, hyper optimization towards the aging health?
My short answer is it's all craziness.
Okay.
My long answer is, listen, I get it. I really like the way a lot of them talk about, if you're going to live to 80, you'd love to live those 80 years in good health, and have a better health span, even if your lifespan isn't better. And there are some things which do help that, right? Don't smoke, exercise, have friends, sleep well, right? All those things. And so most of the longevity people, the first half of what they do sounds great and makes perfect sense. And then they kind of spiral out of control. And what they're doing is they're extrapolating data from, mouse studies or from, sort of pathophysiologic explanations and saying, oh, this is going to be the thing that keeps you alive. So taking rapamycin, taking ketamine, like whatever, this is going to help you. And that stuff, we don't know. And most of our experience has taught us that it doesn't work because improving life expectancy, other than doing the things that we've already done, cleaning up the food supply, vaccinating people, does not help. Okay. Now, listen, I'm almost 60. I'd be the first person to take a medication that guaranteed another 10 years of healthy life. But I am certainly not doing that until there is robust evidence behind that. And if you want to take advice of some crazy person who's trying to sell you, a bottle of stuff that you don't even know what's in it, be my guest. I'm a capitalist like everybody else. But you should not put too much stock in that.
So you are on Twitter and you are active on that. There is a handle called Gurvinder Bogal, or if I'm not wrong, his name is that. And he has written perfectly about this. Is one of the biases that you have mentioned, like in the thread, that there is a healthy influencer bias. A person who is having a right amount of diet, nutrition, exercise, movement, sleep and recovery, and mental and emotional or stress management is about to have a good generalistic healthy lifestyle, and upon which he tells people that I am taking this magic pill, you should also take it. So it is like you mentioned in the numerical stuff, that from 100%, 95% of heavy lifting has been done by lifestyle, or his, what you say, diet, nutrition, exercise, and his entire lifestyle design. And just 1%, or maybe the questionable 1.5 or 0.7% is due to the supplement that he is taking, or due to the magical pill that he is taking. But the person views it as that 95% of his healthiness is related to that magical pill. So that is the bias that I think is pretty much common in medical also, and in wellness industry as well. Now, coming to the statistics, I want you to teach me this, because I want the people, the viewers, to uplift themselves or to upskill themselves with evidence-based medicine and also biostatistics, so that the next time they encounter a person or a doctor telling them to take this drug due to the latest medical research that they are following, they can question them with this knowledge, and also they can review the content creators' claims.
So I think the most important thing for patients or healthy people just seeing a doctor, to try to be healthier, to know, to recognize, and mostly we all know this. We just have to, be aware of it in the healthcare setting, is the difference between a relative risk reduction and an absolute risk reduction.
Yeah.
So relative risk reduction is relative. It's how much better in a percentage wise will I do taking this drug, okay? And a relative risk reduction may be, say, 50%, okay? I'm going to do 50% better with this medication. And that sounds great. And that's usually what we're going to hear on the news, read in newspapers, that's the benefit that a pharmaceutical company is pitching about this. And a 50% risk reduction may be huge, because it may be that, like, without this medication, 90% of people are going to die. And with this medication, 45% of people are going to die. And if that's the case, that is mind-bogglingly good, and you'd have to be suicidal or a crazy person not to take that medication.
Yep.
More often than not in medicine today, the difference in a 50% risk reduction is from 0.05% to 0.025%.
Okay.
And what that means is that if you don't take the medication, you're going to be fine, right? There's a 99.5 chance that you're going to be fine. If you do take the medication, that benefit goes up to 99.25, whatever. I'm losing track of my numbers. But you get it. And so when you read reports, when you speak to physicians, you really have to hear about absolute risk reduction. And the nice thing about absolute risk reduction is if you just take the inverse of the absolute risk reduction, that's the number needed to treat. So that's the number of patients who needed to be treated with a medication for a certain amount of time to have a benefit. Okay. And so if the number needed to treat is 1,500, that tells you that most people who use the drug are not going to benefit, right? It's basically 1 in 1,500 is going to do better. If the number needed to treat is 20, and the outcome is something important like death, right? That means you got a 1 in 20 chance of avoiding death by taking a medication. That's a medication I'd sign up to take. And those are important numbers to ask for, talk about, think about.
Sir, from the foundational lens, how should people review a research paper? Let's say I'm a content creator, I'm not a doctor, I'm just what you said, telling them that this will prevent you from having an heart attack, and I'm quoting a study. Now, what is the first thing that you need to look? Because there is a randomized control trial, there is a observational study, there is a cohort-based studies, there is case-controlled studies. How can a layman, we two are doctors, but how can a layman differentiate between these three and need to focus on one rather than the all?
Yeah, it's a super complicated question, and I don't want to sound like I'm selling product, but it's a 10-year-old book. It's probably easy to get for free on the internet. Our book, Ending Medical Reversal, does have a couple of chapters on kind of reading the medical literature and how to ask questions to your doctors. For me, I think about observational studies, studies where what the doctors did is they said, oh, I found one group of patients out there in the world and another group of patients out there in the world who are exposed to something, not exposed to something, who are eating something, not eating something, taking a med, not taking a med, and I compare those. I would say as a patient, you ignore those studies.
Yeah.
Those studies are for investigators, researchers to generate hypotheses of things that can be tested. For patients, what's important are randomized control trials. These are actual experiments that are done when a group of people is randomized to one treatment or another treatment. So those groups of patients are essentially identical in their risk of an outcome, except for the treatment that they've been prescribed. Those tend to be robust studies. Now, they are not perfect. They are prone to error. But from a patient perspective, that's probably the one thing you need to ask. Is there experimental randomized control trial evidence behind this therapy you're recommending to me?
Sir, you had a 5-point action plan for the patients so that they aren't a victim of medical reversal. Can you quote that? Because there were also red flags which I want to cover afterwards. But just for right now, what are the 5-point action plan that you mentioned in your book?
Yeah, I won't, for sort of simplicity's sake and brevity, I won't go through all 5 points, but I think the main thing is have a doctor who you can talk to, okay, who you can have a conversation about this, a doctor who you think is actually knowledgeable about the literature, okay? Number 2, when the doctor says, this is a medication I'm suggesting you take, ask them, is there an RCT behind this? If the answer to that is yes, say, okay, what is the outcome it will benefit? Is this a surrogate outcome like we talked about, or is this a clinical outcome? And then if it's a clinical outcome, ask, how likely am I to experience that benefit? And if it is, well, you're 90% likely to be fine without the drug and 99.5 with it, that's probably something you can pass on. If it's more 60%, without it, 80% with it, that's probably something you'd want to consider.
So one of the questions that I failed to ask you was that the red flags, because whenever we see a study, they have abrupted it in midpoint, like they have not extended it for the long term, and they have abruptly stopped it whenever they found a positive effect. So that is a red flag, right? And there is also a funding bias that you mentioned in the book. Can you explain the 2-3 points when it comes to the red flag that we need to look for whenever we read a research paper?
Sure. So first, early termination of studies is a really interesting issue. So when people enter a randomized controlled trial, right, they are randomized to treatment or placebo. Both groups are taking a bit of a risk, right? The placebo group is taking a risk that maybe they're not getting a beneficial treatment. And the treatment group is taking a little bit of risk that maybe they're getting a medication which they're taking every day, which may have some toxicity that does nothing for them. And so we promise those people that as soon as we know that one treatment is better than the other treatment, we're going to stop that trial, okay?
Yeah.
That is an ethical necessity. The fact is, though, is that some trials have to stop because of that ethical necessity, and it actually sort of gets in the way of finding truth. Because we found that trials that are stopped early tend to overestimate the benefit of treatment in a systematic way. And so just because one trial has been run and stopped isn't a guarantee that that's an effective treatment. Fortunately, there are often other trials going on at the same time, so often we end up with a lot of information over the long term. And this might be one of those reasons to don't rush out and get the newest treatment. Maybe not give it 10 years, but maybe give it a year or two to let other people take the chance on it first.
Sir, I want to end this with, Yeah, I want to end this with two important questions which are not in part of the book, but I think after a decade of its publishing, it is really apt for me to ask this right now. Let's say there is someone who is a victim of medical reversal. Let's say someone is on a statin. Let's say someone is on a GLP-1 drug, or let's say someone is on a metformin or anti-diabetic medication, and his condition doesn't warrant him to take that medication. What he should do, what's the next step he should do? Because there are a lot of people who will be preventing themselves from becoming a victim of medical reversal. But I want to talk about on behalf of a victim. Like, if already, let's say he's a middle-aged person, 45 to 50-year-old, he's been taking statins as a part of a primary prevention. He's not high risk, he's low risk. He has to discontinue the statin because, as you mentioned, the number needed to treat for a primary prevention in a low risk individual is minuscule, and he needs to take off from his medication. What are the next steps as a victim?
Yeah. I'm gonna push back on the victim, because I'm gonna hope that what happened is that person started the medication without kind of adequate knowledge. Okay, didn't understand that the chance of benefit is small. Maybe because he didn't have that discussion with his doctor. Maybe the doctor didn't know, didn't have time, whatever. And then that person reads or uses an AI tool and sort of figures out, oh my God, my 10-year risk is 3%, and the absolute benefit of this medication is, 0.2%. And my view of healthcare has changed, that I'm a little bit more of a less is more kind of guy and less of a maximizer, and I don't want to take this anymore. Then I think the thing to do is probably go to your doctor and say, listen, this is my reasoning. I want to stop this medication. Make sure you're not missing something because, we're all not perfect. And if your doctor's sort of like, yeah, you're right, those are the numbers, I think you should take this medication, then you disagree with your physician, which is absolutely fine. And you say, okay, well, this is not in line with how I want to take care of myself. I'm stopping this medication. Your doctor should say, okay, that's great. I'll make note of that. And, that's the end of the story. If your doctor says, oh my God, that's a terrible mistake, I can't keep taking care of you, that's not the right doctor for you. And you need to find somebody else, because we are all in charge of our own healthcare.
Yeah, right. Sir, the last question for me is for the general public. They are already exposed to various kind of contents, and they don't know the credential of the person. They know that Dr. Adam Cifu is really a decade-long internal medicine doctor. They know that Dr. Smith is a new age kind of preventive health expert doctor, but they don't know the XYZ person who just claims to be a doctor as a part of his branding, or is wearing a coat, or is telling a testimonial of his coaching client, or is telling a anecdotal experience of his one of friend who was under his guidance and he did a drastic transformation. What is your criteria for a quick review for this person? Like, let's say there is a XYZ person, he's telling statins are poisonous, you have to take them off the radar. Or let's say they are coming up with new age study that if you take metformin or if you take rapamycin, you will live 10 years more than the last decade, or health span extension and all that. What's your quick review for this, and what's your quick advice for this person? I will start with mine just for a conversation. One of my fellow creator, he is a computer science graduate, and he is also into this health and fitness industry, and he is into this AI. He is really a top guy in the top MNC of India, and he has come up with a framework called EBM SORT-A, evidence-based medicine SORT-A, which is one of the top meta-analysis, one of the top peer-reviewed kind of consensus guidelines for the person to be reviewed under evidence-based healthcare. So let's say someone comes that statin is good for primary prevention. Just type EBM SORT-A on your AI chatbot, and you will have the report, the evidence-based report. That's what I tell in my lectures. That is what I tell in my keynotes at corporates. What about you, sir? Because you are into this content creation yourself, and also you are into this public speaking as well. What's your last takeaway for our viewers, just to equip them with one of the final tools to fact check any claim?
I think that's a terrific suggestion. The things that I often recommend, the Cochrane group, which does meta-analyses, Basically anything which has significant data behind it has been analyzed by Cochrane, and you can just pull up easily on the internet, the Cochrane website, put in questions. You'll find where support is, where there's not support, and most importantly, where there haven't been studies at all.
Yeah.
And if someone's telling you to do something which hasn't been studied, you know they're just kind of making it up. The other things, although I have a lot of problems with clinical guidelines, right? So expert societies coming out with guidelines about how osteoporosis or diabetes or hypercholesterolemia should be managed. Those guidelines, if anything, tend to err on the more aggressive side rather than the less aggressive side. So if a treatment is not being recommended there or is being recommended with an incredibly low data foundation, you gotta question where that recommendation is coming from.